I'm Oscar Llorente, and I'm the Network Development and Community Relations Director at Mount Sinai Medical Center. I would like to take this moment to announce our new Orthopedic Department, the Columbia University Division of Orthopedics at Mount Sinai Medical Center. This partnership with Columbia gives you access to the only Ivy League affiliated orthopedic program in South Florida. This newly formed team of specialists has trained in some of the most prestigious schools in the country, with a focus on a variety of specialties, including foot and ankle, hand and upper extremity, shoulder, knee, and sports medicine. Today, I'm pleased to introduce you one of our 3 specialists, Dr. Danica Vance, who specializes in sports medicine. She's going to talk about exercise and sports injuries and how to avoid them. Thank you.
All right, I'll take over. Well, thank you, Oscar, and thank you, everybody, for joining. I'm going to go ahead and share my screen so we can get started. Can you guys see this? All right. So as Oscar mentioned, my name is Danica Vance, and I'm one of the new orthopedic surgeons here at Mount Sinai Columbia Orthopedics. And today we're going to talk about exercise and sports injuries. So just a little bit about me before we start. So I did my undergraduate at Duke University, so I am a true Blue Devil at heart. I then came down here and did my medical school at the University of Miami, and then went up to New York City to do my orthopedic surgery residency at Columbia. I went back to Duke then and did a shoulder and sports medicine fellowship at Duke University. As far as interest, I'm interested obviously in sports injuries, shoulder surgery, knee surgery, sports team coverage, and then basic science and translational research. The goals of this talk, or what I want to portray to you guys, is 1, I want to introduce you to common sports injuries of the shoulder, elbow, hip, and knee. And then I want for you guys to get an idea or understanding of when to seek out an orthopedic evaluation. So let's get into it. We're going to start with shoulder pain. And this is probably one of the most common things I see in the office, shoulder inflammation. And what this is swelling, redness, or irritation of the shoulder's tendons or surrounding tissues. So there's no tear of the actual tendons, but the tendon itself and the tissue around it is inflamed and irritated. And this is often caused by repetitive activity above the head. Patients present with lateral shoulder pain. So this is pain on the outside of your arm that also often travels down your arm. Pain with overhead movement. You don't typically have weakness with this, and you have a normal range of motion. It may be painful to move your arm, but you can move it. The mainstay or the first line treatment here is 1, avoiding the exacerbating activity. So avoiding that activity that's causing this pain, doing physical therapy, and pain meds like anti-inflammatories. Acupuncture has been shown to help with this condition, and also steroid injections that we can do in the office, as shown into the picture on the side, can also really help relieve these symptoms. As far as prevention, doing an ergonomic review at work, so making sure, or where you spend most of the time, so making sure your desk isn't too high, that's putting strain on your shoulders, and then regularly doing motion and strengthening exercises for your shoulder muscles really helps. Moving to the rotator cuff. So one of the more common questions I get in clinic is, what are the rotator cuff muscles? And they're shown here on the picture to the side. They're the 4 tendons and muscles that surround the shoulder joint. And you can see here that you have 1 in the front, 1 at top, and 2 in the back. And they have a twofold function. The first is that they help raise and rotate the arm. And then probably more importantly, what they do is they keep the ball, the humerus, centered over the socket, the glenoid. So they're very important in maintaining the congruency of the shoulder joint. When we talk about a rotator cuff tear, what we're talking about is a tear of 1 to up to 4 of the tendons at the insertion of the humeral head, as shown in the picture to the side. This causes shoulder pain that is worse with overhead activities. It often causes night pain, and you have weakness in the shoulder and in moving the shoulder. Who gets it? So it is to note that especially as we get older, a large percentage of us have asymptomatic cuff tears that we don't even know about. Studies have shown that people 60 and above, 30% of those have asymptomatic tears, and that goes up to 65% for those 75 and above. Otherwise, throwing athletes get this, and then older individuals after a fall or a shoulder dislocation. Additionally, you can have that chronic shoulder pain or degenerative tear, and that's a tear that's going to be caused from the normal wear and tear of life on the shoulder. As far as the treatment, it depends on what type of tear it is. So for those degenerative tears, the ones that occur just over time from wear and tear, the first line of treatment is physical therapy, anti-inflammatories, and shoulder injections. We do surgery for these, and we often, most likely these days, it's an arthroscopic rotator cuff repair. That is reserved for those degenerative tears that don't respond to non-operative treatment, or the acute tears that often occur, or can occur after a fall. For prevention, again, doing regular strengthening and range of motion exercises for your shoulder really helps and protects your rotator cuff. One thing I do tell patients that go the non-operative route is that 50% of symptomatic tears get larger over the next 2 years. And what this means and why that's important is that larger tears can be harder to repair. Moving on to traumatic shoulder instability. So this is when your shoulder dislocates or you get a subluxation. So the patient often say they felt the shoulder pop out and then they're unable to move the shoulder. This is usually relocated by either the emergency department or a trainer or a coach. And as far as treatment, this really does need an orthopedic evaluation or follow-up. You often have soft tissue and bony injuries with these, and they often require surgical intervention to prevent them from popping out again in the future. Moving to the frozen shoulder. So this is pain and reduced motion of the shoulder, hence the name frozen. And this can either be secondary to an injury or a surgery, or be primary of unknown cause. There are people that are more likely to get this, and that includes women, diabetics, and those with thyroid conditions. And I want to take you to this picture over here. This is the inside of the shoulder, and what I'm trying to get, or trying to have you see here, is this tissue that is all inflamed, red, and thickened, and that's not normal. And that's what we see in this condition when people have a frozen shoulder. Regarding the treatment, I think this is one that if you feel your shoulder is painful and stiff, like you cannot move it past a certain amount, then you should go see an orthopedic surgeon or get an evaluation, because this is something that the sooner that we get to it and start treating it, the better the outcomes can be. And the first line therapy treatment is steroid injections with physical therapy for gentle stretching and gentle painless range of motion. If that fails, we can do a surgery where we do an arthroscopic capsular release and manipulation to help get your motion back. Moving to the elbow. So we're going to talk about two elbow conditions that are really common that many of you guys have probably heard of. The first is tennis elbow or lateral epicondylitis. This is pain and inflammation on the outside of the elbow, and this is usually an overuse injury of your wrist extensors. So if you look at this picture on the bottom, these muscles and tendons, these are the muscles that extend your wrist or bend your wrist backwards like this. And they all insert on this bone on the outside of your elbow. So you can imagine if you overuse them, this gets really irritated and angry. Who gets it? So 50% of tennis players get this, hence the name. And then also as well as laborers, those that do repetitive gripping and lifting tasks. As far as tennis, the reason people get this often is a poor swing technology or a too heavy racket is something I see as well. Treatment-wise, rest, pain medication, physical therapy for stretching and grip strengthening, bracing, and then adjusting the tennis mechanics if needed be. I will do steroid injections for these. Usually, though, I reserve those for if rest and physical therapy has not helped you. And then if all else fails and it's still really bothering you and it's very symptomatic, we can do a surgery where we debride the inflamed tissue. Now, if we move to the other side of the elbow, we have what we call golfer's elbow or medial epicondylitis. And this is pain and inflammation on the inside of your elbow. And this is overuse injury of the wrist flexors. So similar to the extensors, all the wrist flexors, the things that bend your wrist forward, insert on the inside of your elbow right here. So overusing them can cause a lot of pain and irritation there. So people who get this are sports with repetitive wrist flexion and forearm pronation during ball release. So golfers, baseball pitchers, bowlers, weightlifters, people who play racquetball, and tennis players. Although the tennis players get it for different reasons. This is often for a poor late ball strike, poor forehand mechanics, as well as they don't have. Sometimes it's because they don't have the vibration dampeners correctly. You also can see this with in jobs with excessive vibration of the elbow, so plumbers, carpenters, and construction workers. As far as the treatment for this, it's really rest, anti-inflammatory, so pain medication, and a long course of physical therapy that works in passive stretching. You also can do some bracing and some ultrasound therapy. I would say with this one, we are much more conservative and tend to go longer with the non-operative management. And that's because there's a very important nerve, the ulnar nerve that some of you guys might have heard of, that runs right in that area of the elbow. And we don't want to do anything that could potentially harm that. That being said, if you're having this type of pain and you're also having shooting pain down your fingers or numbness and tingling in your ring finger or your pinky, you should see an orthopedic surgeon because your ulnar nerve might be involved, and that is a little bit more serious. Moving to the hip area, two of the common injuries I see. First is a hip flexor strain. This is injury to the muscles that help lift your knee to your body. So this causes anterior hip pain or pain when lifting the leg to the chest. This is common in soccer players, football, runners, dancers, and cyclists, or those that sit down for extended periods of time. This really responds well to just resting and some anti-inflammatories, pain medication, and then physical therapy for strengthening and flexibility of those muscles. The other thing I see often is trochanteric bursitis of the hip. This is lateral sided, so pain on the outside of your hip, and you can even have tenderness there that is worse with stairs. This comes from repetitive trauma or irritation caused by the IT band rubbing over the greater trochanteric bursa. So this is kind of shown here in this picture on the side. So you have this muscle and fibrous tissue that runs right over this bone right here. And this bone, most of us can all feel. It's the most prominent bone if you touch in your hip areas. And just repetitive rubbing of this can cause irritation and inflammation and cause pain. I see this in female runners, and especially those training on banked surfaces, as well as I often see it in bicycling, especially stationary bikes where your seat is too high. So if you're having this, then I would readjust your seat. It would be the first thing. As far as treatment, again, this responds well to stretching, icing, pain medication, physical therapy, and then sometimes we can also do injections in the office that can help relieve the symptoms. So moving to the knee, one of the most common things I see in the knee is patellofemoral pain. So this is pain in the front of the knee. It's activity related. It's usually from knee bending. So it's worse when you bend your knee. And this is due to inflammation of the bone and soft tissue surrounding the kneecap. Usually this is an overuse injury, but you can also have some patients that have what we call malalignment of the patella. And what that is that when you bend your knee, the kneecap just doesn't sit where it needs to be, or doesn't sit correctly in the groove, and that can cause the pain. This is seen in adolescents and young adults. I often see it in females more than males, and you get it in about 20% of jumping athletes. The other area I see this a lot is when people have recently increased their activity. So they went from never working out to working out 5 times a day, and they're doing a lot of HIIT training. And that's because you're doing a lot of, in those type of exercises or workouts, you're doing a lot of squatting and bending and lunging that just puts extra stress on your kneecap in that region. As far as the treatment, rest, pain medication, physical therapy, and then also another thing that people often help people is doing this taping or strapping right below the kneecap, as this takes some pressure off that tendon in that area of the knee and can help relieve and help with the symptoms. Moving to the meniscus, another common question that I get from people are, what are menisci? And so this is a good picture that I think illustrates that. So they are two C-shaped structures. You have one on the inside of the knee and one on the outside that sit on top of the shin bone as shown here. And they are sitting on top of the articular cartilage. And they are your shock absorbers. And so they really are important in that they transmit 50% of the weight-bearing load across the knee. Additionally, they protect the articular cartilage, and so they're very important in preventing osteoarthritis. When we talk about meniscal tears and what it is, so this presents with pain that's localized to the side of the injury, so to where the meniscus is torn, either medial or either on the inside or the outside of your knee, and they present with joint line tenderness, so tenderness right along the knee joint. Additionally, patients often have clicking, locking, especially with squatting, and you can have pain with twisting. As far as who gets this, it's really a twofold. So in the young, these are sports-related injuries, and they're often common with other types of injuries, such as ACL injuries. You know, this is where a patient has or an athlete has a twisting injury and gets swelling of their knee, and then has clicking and locking symptoms. If that's the case, then you really should see an orthopedist doctor. The other people that get it, similar to rotator cuffs, are older individuals, and this is the more degenerative condition, just wear and tear over the years on the knee. Regarding the treatment, it really depends on what type of tear it is. So for the degenerative tears, the ones that occur over time just from wear and tear, the mainstay is rest, pain medication, and physical therapy. We can also do injections that help as well in the office. If that all else fails, then we can do a surgery where we do a partial meniscectomy where we remove the torn part. In acute tear, so those that occur, after a sporting injury, again, those need an orthopedic evaluation, and those are more likely to be pushed towards surgery. And those are, if possible, we like to do a repair of those versus a meniscectomy where we take the torn part off. I have saved the meniscus there because I'm a big proponent of repairing and saving the meniscus whenever possible, because it really does protect that articular cartilage and prevent osteoarthritis. A question I commonly get in the office is, how do you know you can repair my tear? And I want to take it to this top picture here. This here you can see, so in order for something to heal, you need to have a good blood supply. And the meniscus is unusual in that only some of it has a good blood supply. And this is shown here. So the red zone is where the meniscus has a good blood supply. So any tear here we can fix. Anything in the white zone isn't going to heal well. And those are the types that we are more likely to remove. Moving on to the knee pain and ligamentous injury, there are 4 main ligaments in the knee, and the way I like to think about them is that there's 2 on the outside of the knee. There's the medial collateral ligament, which is on the outside of the knee joint, but on the inside of your knee, so on the medial side of the knee, and then the lateral collateral ligament, which is on the outside or lateral part of your knee. And then there's 2 ligaments that are inside the knee joint itself. That's your an anterior one, that's your anterior cruciate ligament. That's the one that a lot of people have heard about because it's most oftenly torn, often in athletes. And then you have your posterior cruciate ligament as well. As far as a ligamentous injury, what is it? So it's tear of injury to 1 to 4 of the knee ligaments. It presents with knee pain, instability and decreased motion. It's often that pop and swelling that people hear. And then who gets it? It's sports-related injuries, like pictured here, or we also often see these also in high-energy traumas and car accidents. And these really need orthopedic evaluation. I'm going to focus briefly on just the 2 more common ligament injuries that we see. The first is the medial collateral ligament, or the MCL. If you remember, that's one of the ligaments that are on the outside of the knee. That's on the medial side of the knee, or the inside of the knee. So it's shown here. And this presents as medial sided knee pain following an injury. and it's caused by inward stress on the knee or a direct blow to the lateral knee. So as a Blue Devil, you know, I had to put a picture of a Dookie in here. And this, if you guys follow college basketball, this is the infamous Zion Williamson injury when he blew out his shoe. And if you see here, it was actually his opposite knee that got injured. So as his left leg when he blew out his shoe, he had an inward awkward force to his right knee, and his right knee bent inwards. And that stretched that ligament that goes right here. So who gets this? So it's the most common ligamentous injury in the knee that we see. So 40% of knee ligament injuries have this. The highest risk is in skiing, rugby, football, soccer, and ice hockey. And also you see it in pivoting and cutting athletes. It's often comes with or is in combination with an ACL injury. So you often see an ACL-MCL combo. And as far as treatment, this needs an orthopedic evaluation. The good news is, though, is of all the ligaments, this one really does heal the best on its own. And so an isolated injury most likely can be treated with rest, bracing, medication, and physical therapy and do really well. Finally, we get to the ACL tear. Again, you guys have probably heard about this in professional sports. This presents with deep knee pain and decreased range of motion. 70% of these are from a non-contact pivoting injury. So typically it's the guy that's running down, goes up for a basketball player running down, goes up for a layup, and then comes down and lands awkwardly on his knee or leg. They hear a pop, or they feel a pop, and they get swelling. As far as who gets this, so females are 4 times as likely to tear their ACL, female athletes, than males. And there's several reasons we think because of that. Additionally, this is seen in soccer, basketball, skiing, and football players. Again, it's often associated with meniscus and MCL injuries. I have a picture of those who follow NFL. The quarterback Joe Burrow just tore a couple weeks ago his ACL. He actually had an ACL-MCL combo, and so that's the injury he had. Treatment, again, these need an orthopedic evaluation. If we suspect an ACL tear, we'll usually get an MRI to confirm, and then most people for this are going to have surgery and get an ACL reconstruction. As far as ACL prevention, I just want to mention briefly, there is a push, especially in the female athlete. And the things that we've worked on is, one is neuromuscular training or jump training. So it's been shown that women or young women athletes tend to land with their knees more inward, as shown in this diagram, and this can put more stress on the ACL. So people work on correct landing techniques to kind of land with the knees more straight and not inward, and that can really help. The other thing they work on, especially in females, is hamstring strength. Hamstrings are the muscles in the back of your thigh. Females tend to have stronger quad muscles, which is the muscles that are on the anterior part of your thigh, and that can put stress on the ACL. So doing exercises to increase the hamstring strength, especially in women, has shown to help. And then the other thing I've seen is educating skiers the correct way to fall so that they don't tear their ACL. So that's really it. That's all I have. I do want to stress my take-home points for you guys. One is that most overuse injuries can be treated successfully with rest. So stopping the aggravating activity, a short course of anti-inflammatories, and a physical therapy or a home exercise program. Regular stretching and strengthening exercises are key to orthopedic injury prevention. And then extremity pain and swelling from an injury often requires an orthopedic evaluation. So if you get hurt and your extremity is swollen and painful and not getting better, please come in and see us. I just want to take a moment to then just introduce our orthopedic department and my amazing partners, Dr. Stephanie Shim. Her and I, we actually trained together at Columbia Orthopedic Residency. She's a hand and upper extremity surgeon, and so as she says it, she covers everything from the clavicle to the fingertips, and she also does microvascular and peripheral nerve surgery. And then Dr. Ettore Volcano, he's our chief of orthopedic surgery here. He's a specialist in foot and ankle surgery, as well as limb realignment surgery. And that's it. I'm happy to take any questions that you may have, but thank you again for everyone tuning in. Hopefully you learned something and can take something home from that.
Okay, thank you, Dr. Vance, for that excellent presentation. At this time, we do not have any questions from the audience. So if you don't have anything else you want to add, we're going to wrap up the lecture now.
All right.
All right. We'd like to thank Mount Sinai Medical Center, Dr. Vance, and everyone who tuned in today. We'll be back again on January 7th with another live lecture on Facebook. So be sure to follow the City of Sunny Isles Beach and Mount Sinai Medical Center on social media, and we'll be sharing information about next month's topic very soon. All right. Thank you.
Thank you, guys.